We are back with another series. Let's revise PYQs. This will benefit you in your upcoming exam. Let's look at the first question from this video. Question 1. A patient hailing from Delhi presents with high fever, arthralgia, retrobulbar pain and extensive petechial rash for 3 days. Lab investigations revealed a hemoglobin of 9 grams per deciliter, a white blood cell count of 9,000 cells per cubic millimeter, a platelet count of 20,000 cells per cubic millimeter, and a positive tourniquet test. What is the most likely diagnosis? Your options are. And the correct answer is dengue hemorrhagic fever. Here's the explanation.
The hemorrhagic element to it. So whatever I have studied for dengue fever, plus if they say that the patient has had a platelet, hemorrhage kab hoga, bleeding kab hoga, when there is going to be a platelet count of less than 1 lakh, either quantitative problem or there is going to be some functional defect. So see, platelet bleeding will happen of two things. Either there is a quantity problem in the platelet. Guys, what is the normal platelet count? 1.5 to 4 or maximum 4.5 lakhs per mm cube is the normal platelet count, right? And they are saying it started falling, but when it falls less than 1 lakh, that is when I'm more and more worried. So platelet count less than 1 lakh or a qualitative defect in platelet is one thing. And also there's a very famous test. We know there's a tourniquet. If you tie a tourniquet, there are going to be hemorrhagic spots noticed. So positive tourniquet test. Also please note, there's another test that we do, that is hematocrit increase by 20%. So what is hematocrit? Hematocrit that you study in pathology is the other name for a packed cell volume, and that has a normal. If I give you a normal male female average nikale, normal is roughly around 45%. So between 35 to 45% you can say. So for example, someone had an hematocrit of 35% to begin with. That female had a hematocrit of 35%. Now she's having a hematocrit of 55%. So the hematocrit has increased. That is again something. Why is that happening? Why? So please remember, this is featuring hemoconcentration. This is an evidence of hemoconcentration that is happening. So what all do you have to know? Dengue fever, hemorrhagic fever mein dengue fever wale all symptoms are there, but hemorrhagic mein you have to know that number one, the platelet count is affected. Second, there's going to be a positive tourniquet test, and the hematocrit is also going to increase by a 20%.
Question 2. A patient presented with complaints of persistent dry cough, fever, and weight loss. He was diagnosed as HIV positive 6 months back and is poorly adherent to his medications. Gomethylamine silver staining of bile reveals a crushed ping pong ball appearance. What is the most likely causative organism? Your options are. And the correct answer is Pneumocystis carinii. Here's the explanation.
And I have already taught you one thing about Pneumocystis carinii. That is, when we were talking not about the cell wall, particularly when we were talking about the cell membrane, if you guys remember. When we were talking about the cell membrane, so I'll quickly revise. I had to revise it so we can quickly study. Remember, every fungus has a cell wall. And what is the cell wall containing? Cell wall contains chitin. Next, every fungus has a cell membrane. And all the cell membranes contain what? They contain ergosterol. But which is the one which does not contain ergosterol? And that was Pneumocystis carinii. Now, before I go into the story of Pneumocystis carinii, I will first tell you one mnemonic, and after that you can keep reading the theory, because once you learn this mnemonic, everything is simple. So how I will learn Pneumocystis carinii is going to be PCP, PCP, PCP. 3 times I'm going to write PCP. Why do I do that? So let me tell you, we'll write PCP thrice because the entire story is finished off in PCP. So P means I am talking about Pneumocystis. The name of the organism is carinii. And what does it cause? Pneumonia. So what is the disease that it causes? Pneumocystis carinii pneumonia. Whenever someone suffers from Pneumocystis carinii pneumonia, remember that person has a lot of plasma cells. So this is also known as PCP, plasma cell pneumonia. This is also referred to as plasma cell pneumonia. Okay, so whenever someone has PCP, Pneumocystis carinii pneumonia, you will see a lot of plasma cells in his lungs. And lastly, why is this known as PCP? Because this shows you the ping pong ball appearance, and that ping pong ball that I'm talking about is crushed. So there is something known as a crushed ping pong ball appearance. Repeating, PCP, PCP, PCP means what? I'm dealing with PCP, Pneumocystis carinii pneumonia, PCP that is plasma cell pneumonia, PCP that is crushed ping pong pong ball appearance. With this entire outline, let's start with the discussion. So when I'm talking about Pneumocystis carinii, someone asks you what are the clinical features. I told you it is Pneumocystis carinii pneumonia. So there's going to be pneumonia features that will be there, and these patients come to you with dry cough. They come to you with dry cough. So that means sputum production is not going to happen. What sample will I then take from the patient? Because when there is no sputum sample, I will have to go ahead with bronchoalveolar lavage. The sample that I take from the patient is bronchoalveolar lavage. And now you will tell me that when I've taken a bronchoalveolar lavage, which are the cells that I will see maximally in it? That's why I called it plasma cell pneumonia. So we see lots and lots of plasma cells under the microscope. Fine. What else did you see? We saw the very famous crushed ping pong ball appearance. So it's time that we start seeing that crushed ping pong ball appearance. So let's see the image that we are talking about. So have a look at this picture. Firstly, why is this picture looking extremely black? It is looking extremely black because we have used something called Gomori methenamine silver. We have used a stain called Gomori methenamine silver stain, and please remember this Gomori methenamine silver word comes and I know I'm getting a black color. Okay, what can you see? You can see some round appearances. Those round appearances are referred to as what? The ping pong ball. After that you say let's crush the ball. So I can see a lot of places where it is crushed. It has been crushed. So now I call it what? I call it the crushed ping pong ball appearance. But then came the people who are good in imagination. They said it is crushed in a manner that it is looking like a helmet. So, okay, they started calling it a helmet or a hat. They started calling it hat appearance, helmet appearance. Then some said some of them are crushed, some of them are round. So, it's looking like a cup and saucer. That came across as another name now. That came across as an other name, that is the cup and saucer. So repeating once again, there is a crushed ping pong ball appearance. That crushed ball can look like a hat. So some of them look like hats, some of them look like cup and saucer. But the stain is something that they will put up to you, because no gram stain or anything is going to help you. GMS will help you. Gomori methenamine silver will help you. Coming back, we have done all of that. We have done the stain. I've told you the stain is Gomori methenamine silver. Can you cultivate it? And the big answer to that, the biggest answer, the biggest no possible that you have to write, because I have already told you in this entire chapter, there are two organisms which are non-cultivable. Can we repeat? One is going to be this Pneumocystis carinii, PCP, and the other one was Rhinosporidiosis. You cannot cultivate these two, Pneumocystis carinii and Rhinosporidiosis.
Question 3. A man presents with a history of dysuria and urethral discharge after having unprotected sexual intercourse. Gram staining of the purulent discharge is shown in the following image. What is the treatment of choice for this infection? Your options are. And the correct answer is ceftriaxone plus azithromycin. Here's the explanation.
Gonorrhea is of course going to cause gonorrhea, so this means there is going to be some kind of genital involvement. So genital में क्या क्या है? I've got you a list. देखो. So think of all, whether male or female, think of all the genitals. So in females you can think of vaginitis, cervicitis, urethritis. In males also you can think of urethritis, prostatitis, seminal vesiculitis. Genitals are affected. Anorectal infection can be seen. So all genitals and anorectal put in one part. What if it happens from mother to child while the child is passing through the vaginal canal? Can it get inoculated into the eyes of the child? Ophthalmia neonatorum, yes. So firstly, all the genital things, because gonorrhea, I told you, na, genital infection hai. So it's going to be all the genital things, and secondly, it is going to be a mother to child transmission in the form of ophthalmia neonatorum. Now, if they ask you, what is the further thing? If I ask you, tell me one thing for male and one for female, which is most common. So let me tell you, cervicitis is the most common in females, and urethritis is going to be the most common in males. Very important. Repeating once again for you, cervicitis is going to be the most common manifestation in females, and urethritis is going to be the most common manifestation in males. In fact, males, they will give you one line which will hint you towards gonorrhea. Urethritis means urethral discharge, cervicitis means cervical discharge. But when they tell you urethral discharge in a male patient, they will always say that there is a flow of seed discharge, basically like semen. There is a flow of seed discharge. Guys, if this word is written, they are indicating you towards gonorrhea for sure. Okay, so you've done all of these also. Now you need to know what further, what can happen. So many genital organs are getting affected. Aage kya hoga? Patient might land up with multiple discharging sinuses. Discharging where? On the skin. There might be like a water can. You've seen that can with which you give water to the plants? They have multiple holes na, for water to come out. Similarly, multiple discharging sinuses is known as water can perineum. What further can happen because of gonorrhea? There are two more complications known as Fitzhugh-Curtis syndrome. This is nothing but perihepatitis. Fitzhugh-Curtis syndrome is perihepatitis, and this is also seen with chlamydia. This I will be teaching you in the later part of bacteriology. This is also seen with chlamydia. Secondly, it can cause all over the body infection. There can be disseminated gonococcal infection. Can you tell me, guys, I have taught you which is the protein that is going to cause it? PORB1A or PORB1B? So I just told you PORB1A will cause a lot of infection. Na? So it is going to be PORB1A causing disseminated gonococcal infection. And you will say, ma'am, disseminated matlab what all organs of the body are affected? There is involvement of skin. There can be involvement of joints. There can be, when I'm talking about joints, I can talk about tenosynovitis also. Again, there can be involvement of the brain, so meningitis, and endocarditis, matlab there is involvement of heart. So some people also learn it as the mnemonic, which I'm going to put up in front of you, and that mnemonic is date me. That mnemonic is date me. So that tells me dermatitis, arthritis, tenosynovitis, meningitis, and endocarditis. But actually, honestly telling you, you don't need this mnemonic, because the fact disseminated means only that head to toe everything's gonna get affected. And what is Fitzhugh-Curtis syndrome? Fitzhugh is just the involvement of the hepatic. Perihepatitis is seen. So they might give you a picture, or they might give you an explanation that there is inflammation around the liver, or there are some fibrotic bands, something around the liver is happening. Perihepatitis situation is happening. That is Fitzhugh-Curtis with gonorrhea, with chlamydia. Now coming to the diagnosis of Neisseria gonorrhea. You know the sample. Depending on what your situation is, if you have a genital discharge, take that discharge. If you have some involvement of disseminated gonococcal infection all over the body, you can take a blood sample. Brain ka involvement hai, you can take a CSF sample. So depending on your site of involvement. And what is the microscopic? This same picture has been asked a million times in the exam. So please zoom in, and all of you can see that there is some kind of an organism which is present as, can you see, diplococci. They will always double, as a double, they are always present in pairs. So they always mention that there is a gram-negative diplococci. See, pehle to as soon as they will mention gram-negative cocci, anyway my options are venom. Velonella, Neisseria, Moraxella, limited. Along with that, if they had mentioned some genital discharge, I know that genital ke saath gram-negative cocci has to be Neisseria gonorrhea. And how do you treatment? Of course, the same ceftriaxone, but you also combine it with azithromycin for the treatment of gonorrhea.
Question 4. What should be the subsequent course of action in managing a patient who presents with fever and a positive result on the filarial antigen test? Your options are, and the correct answer is detection of microfilaria in the blood smear. Here's the explanation.
So infective form, remember, infective form जो फैल रहा है, that is the filariform larva. So that picture you will never see, that will come in your body. The picture that you will always see will be what you will see in the stool sample, and that stool sample is a rhabditiform larva. How do I identify a rhabditiform larva? Is like any other, it has one end which is going to be blunt like this, one end which is going to be pointed, okay, still. But if you will look in the center, there is a notch in the esophagus. If you look in the other one also, there is a slight notch in the esophagus. This is known as the double bulb esophagus. This is known as the double bulb esophagus. So if you go back and you realize, how did you analyze a rhabditiform larva in the stool? By the double bulb esophagus. So simple, rhabditiform is going to be in the stool for recognition. Okay, now we can give you the final mnemonic. Rhabditiform larva is what you are going to use for recognition, and filariform larva is what you're using as infection. So what else can filariform larva cause? Filariform larva is also capable of causing hyperinfection and disseminated infection. So I'm coming to all these infections. Let's come to the clinical features. So first and foremost, is it capable of causing cutaneous larva currents? Not cutaneous larva migrans. That was caused by hookworm. That was caused by hookworm, and that was ankylostoma. This is cutaneous larva occurrence because it is coming via the skin. Yeah, then you told me small intestine and lungs में जाएगा तो वो तो होगा, that is understood. But what did I just say? It is gonna be causing hyperinfection and disseminated infection. What is the difference? Hyperinfection syndrome basically means when it is going into a severe form. Severe form means that organs, the same organs, GIT and lungs, but it's a more severe form and load of filariform larva is more. Disseminated means it is going to all the other organs of the body also. So repeating, the hyperinfection is the same organs but more load, right? GIT and lungs hi hain, but more load. Disseminated means all over the body, and both of these are obviously going to be associated with the filariform larva because wo phailta hai. That causes hyperinfection. That causes dissemination.
Question 5. Which of the following medium can be utilized to determine the probable species of the causative agent in a female patient presenting with symptoms of thick curdy white vaginal secretions and microscopic examination of vaginal scraping shows budding yeast and pseudohyphae? Your options are, and the correct answer is Chrome-agar. Here's the explanation.
Candida is also grown on another agar known as the Chrome-agar. Candida is also grown on Chrome-agar. So that will tell you chrome. Chrome means what? Multicolored. You're going to get an agar with a lot of colors. So again, C for C. Chrome-agar is something that you grow. Candida.
Question 6. Which of the following is considered to be the best for the detection of Clostridium difficile? Your options are, and the correct answer is toxin assay. Here's the explanation.
How are you going to do the diagnosis? Some things are common sense. Sabse pehle you will say that, ma'am, I will do colonoscopy. I will try to look at the intestine. It's very, very specific, of course, because in the intestine, if you can do a colonoscopy and see the membrane, there is nothing better than that. There is obviously going to be a specificity, but that means that if present, it is definitely Clostridium difficile. But it is not seen in many of the cases. So its sensitivity is very low. But if present, it is 100% specific, but is not seen. So sensitivity low hai. What can you do next? You can obviously, the point is you will have to find out the toxin. How will you find the toxin? Lots of methods to find the toxin, which I'm going to come to. You can do a toxin tissue culture assay. You can culture it. So you can do whatever membrane is there. You will do tissue culture assay. You can use ELISA. Okay.
Question 7. A truck driver with diabetes visits you complaining of cough and difficulty breathing. Pneumonia has been diagnosed, and histopathological examination indicates the presence of non-septate hyphae branching at wide angles, as demonstrated below. What is the probable cause of this condition? Your options are, and the correct answer is mucor. Here's the explanation.
So first and foremost, if you guys remember what was aspergillus, then other things are opposite. So tell me, in aspergillus, what was the branching? There was an acute angle branching. So in mucormycosis, what is the branching going to be? Either it's an obtuse angle branching or it's a perpendicular 90-degree branching. Bilkul opposite. Okay, aspergillus was what? SPE, that is, it had septate hyphae. It had septate hyphae. So what is mucor going to have? Mucor is going to have aseptate hyphae. Mucor is going to have aseptate hyphae. And one last thing, remember, mucor and M and R, mucor is mota. Okay, if they ask you which is the broader one, which out of aspergillus and mucor, which is broad and which is like a ribbon, so remember, mucor is broad, M for mucor, M for mota.
Question 8. What is the likely vector for the disease in a patient from Uttar Pradesh who presented with symptoms of fever, pallor, hepatosplenomegaly, pancytopenia, peripheral smear examination showing macrophages laden with organisms containing a kinetoplast? Your options are, and the correct answer is sandfly. Here's the explanation.
Kala-azar matlab, the reason why it's called Kala is because there is a pigmentation of the skin that you can very well see over here. There is a dark, blackened, scaly kind of a skin. So Kala word actually comes from that. Apart from that, you will see, so first and foremost, I'll write the word Kala because that tells me dark, ashen, pigmented skin. You will also see a protuberant abdomen because these patients come to you with hepatosplenomegaly. And let me tell you, there is massive spleen that is defined in these patients. There is massive spleen hepatosplenomegaly that you're going to see in these patients, right? These patients have hepatosplenomegaly. Apart from that, there are symptoms of any infection. There are fever, there is weight loss, there is weakness, night sweat. So these are, common symptoms of every infection, but the two main things are the pigmentation and the protuberant abdomen. However, there is one rare variety. And what is that rare variety? If the patient is HIV positive and the patient ends up having Kala-azar, we have seen that many a times that hepatosplenomegaly is not seen. This is an atypical presentation that you can see, that if it's HIV positive patient with Kala-azar, you might not see the protuberant abdomen. Now, this is the patient of Kala-azar in front of you. Of course, with this, you will obviously want to tell me that, ma'am, diagnosis bana do, treatment kara do. Simple as that. So, how are you going to do the diagnosis over here? Please note that for the diagnosis, first question that will come to everyone's mind is sample kya lenge. So, the sample, of course, is the very, very famous spleen. This question has come a million times in the exam. There's a long list. Okay? So, they ask you in terms of sensitivity, which is the best sample that you should be taking. I should be taking an aspiration from the spleen. But do you think two very common problems that I can see? Spleen, firstly, the spleen is huge at this point of time. It's a case of Kala-azar, massive splenomegaly ho rakha hai. Secondly, spleen is an extremely vascular organ. So it can be quite disturbing because it's very vascular. It can result in a lot of bleeding. So spleen hai to best, but what is the most preferred will be a bone marrow. After that, you have a lot of other samples, like for example, you have the blood. You can even do a bronchoalveolar lavage if you have an HIV positive person, because HIV positive person, I was telling you, spleen and liver are not very commonly involved. So you might get to see it in the lungs. HIV mein to disseminated infection is noted. So yeah, these are the samples, but the question, let me tell you the question beforehand. The most sensitive sample of leishmania that you're going to get is going to be from the spleen. After you get it, or whether you got it from the spleen or the bone marrow, what will you see? You'll say, ma'am, pro-mastigot to infection kara raha tha. Diagnosis ke liye I need A-mastigot form. So, if I ask you out of these two, which is A-mastigot and which is pro-mastigot, so you'll say very simple. The first point of this chapter that you told us was that A-mastigot form is going to have absent flagella, and I do not see any flagella coming out of it. I don't see any flagella coming out. Yahan par stop ho gaya. So, this is one thing. Next, you told us that there will be a nucleus, and then you told us there will be a chota sa dot, which is a kinetoplast. That is how I will identify this is, guys, what is known as an LD body. The other form jisme flagella dikh raha hai, that must be the pro-mastigot. I am not much interested in pro-mastigot. My diagnosis does not depend on pro-mastigot. My diagnosis depends on these LD bodies, A-mastigot.
Question 9. An unimmunized 2-year-old child presented with cough, coryza, conjunctivitis, and bluish-white spots in his buccal mucosa near the lower molar teeth. A day later, he developed a maculopapular rash on the face and neck. What is the nature of the causative virus? Your options are. And the correct answer is enveloped ssRNA. Here's the explanation.
And I want to tell you some one or two differences, although if you look at the beginning of the chapter, I have told you all the differences, but now I'll show you the diagrammatic representation. So have a look at this. Under Orthomyxoviridae, if you remember, could you see that the genome was approximately 8 segments, right? So there was a segmented RNA that you could visualize over here. Whereas when you're coming to Paramyxoviridae, there is a single RNA. There is no segment that you see. It is a non-segmented or an unsegmented genome that we are going to have. Second, if you remember, in Orthomyxoviridae, one of the molecules that you had on the surface was hemagglutinin, and then the other one that you had was neuraminidase, right? Whereas if you see over here, in case of Paramyxoviridae, you will see that hemagglutinin and neuraminidase are on the same spike. They are on the same spike. So that is one thing that we see over here. Second, we see something extra, and that is known as the F protein. There is a protein called the fusion protein or the F protein, which is present in members of the Paramyxoviridae family. Now let's move forward. What are the things that are going to come under this? I think I've already told you. There is MMR to begin with. M stands for measles. Then there is measles virus, then mumps virus. Then everyone believes I'm talking about the vaccine MMR, but R is not for rubella. R stands for respiratory syncytial virus because rubella does not come under this family. Okay, coming to the next, para-influenza. For Paramyxoviridae, we have to think of para-influenza. And we also have Nipah virus, which is going to be discussed over here. So these are the different viruses that we need to know. I'm starting first with the measles virus because that is something you studied more commonly in pediatrics also. Now, what is the other name for measles virus? It is also known as rubeola. So I hope you know the difference between rubella, rubeola, measles, German measles. There's a big, confusion that they have created, and I will sort out that confusion for you. So whenever you're talking about measles versus there is something called rubella, so you have to do a cross connection. So remember, rubella is not rubeola. Rubella is different because the other name of measles is said to be rubeola. So you can't keep the two similar things together. So measles is rubeola and rubella is said to be German measles. Rubella is said to be German measles. So simple, keep the measles and the measles away, keep the rubella and the rubeola away. That is the rule over here. So remember, measles is known as rubeola and rubella later on will be known as German measles. Okay, what is the incubation period? Mostly in children, this is going to be 10 days, and for adults, it's a little longer, 21 days. Again, something which students have a problem in learning. So let us go for the vaccine. Your favorite vaccine, MMR, measles, mumps and rubella. So when you're talking about measles, mumps and rubella, and they ask you that what are the incubation periods of these particular viruses, first you're going to make a 10 because measles, as you can see, is going to be an incubation period of 10 days. After that, from that 10, you are going to make a line at the bottom. What does that become? For mumps, it becomes 19 days. Okay, then from that 19, what can I do? You will make a straight line. So for rubella, it becomes 14 days. Remember, it is 10, 19 and 14. So 10 may say you're gonna make a line that becomes 19, then you make another line that becomes 14. So 10, 19 and 14 are the incubation periods. That is why for measles, I wrote 10 days. What is the transmission? You know, measles is by obviously the respiratory droplets, which is going to be the inhalation of these droplets, and that is how it will get transmitted. So now let us know who are going to be the sources and what is the period of communicability. Basically, I'm also touching upon the PSM aspect. Source, of course, is going to be the case. The person who has been infected, a measles virus infected person becomes the case, and that is the source of infection, and there is no carrier state that is ever known. What is the reservoir? We. So simple. We as patients are the reservoirs. We as patients are the cases. And what is the period of communicability? So please remember, whenever the person has rash, from 4 days before the rash to 4 days after the rash, the person is in the period of communicability. Fine. What is the immunity with measles? This I'm sure you've heard, a lot that measles has a lifelong immunity. That is why it's, once someone is infected with measles, that person is immune for a lifetime. But why is that so? Because that person is infected with a single serotype and there is only one serotype that exists. So once you get an immunity for it, you're always going to have immunity. Okay, if you've understood this, now let me come to the most famous question. The most favorite question that they have, the 3 C's. How are you going to pick up measles? What are the starting symptoms, prodromal symptoms? Of course, it's a fever which every virus shows you, but it's the 3 C which you have to be which they're very fond of asking you. So what is this 3 C concept? There is cough, coryza and conjunctivitis. So remember, these patients have cough, coryza and conjunctivitis. That is something that came in the recent 2023 exam also, which is very important. So cough, coryza, conjunctivitis, please watch out for that. Moving on to the next one. This was only your prodrome, because now what is the actual first manifestation out of all of these? Out of these, fever is the first manifestation, and we know that fever occurs on the 10th day. Now you will keep adding 2 days, 2 days, 2 days. So 10th day par kya hua? Because what was the incubation period? The incubation period was 10 days. So on the 10th day, that is the first day of the symptomatology, what is the condition? Fever. Now what happens after that? After that comes the most famous spots called the complex spots, which are seen by the 12th day. And after that, you see a rash, which is seen on the 14th day. So if I ask you what are the 3 days in which this goes on, remember it is going to be fever on the 10th day, complex spots on the 12th day, and rash on the 14th day. Now let me elaborate on this. Fever, you don't need any elaboration on, I'm sure, but you would want to see what are these complex spots. So these are the pathognomic complex spots that I'm seeing over here. And where do you see them? You can see them near the molars and remember how many days. So you will remember, ma'am, 2 days you were adding. Pehle you were seeing fever, so roughly 2-3 days later you are going to see the Koplik spots, and roughly 2-3 days later after that you will see the rash. So it is seen on the molars. It is seen on the molars 2 to 3 days after fever. But how do they look like? Molars ke paas to theek hai, but how is it looking like? So if you look very carefully, there is a white color dot, and surrounding that white color dot there is a reddish base, है ना? So what did I say? There is a white color dot, and surrounding that there is going to be a reddish base, and that is the description that you have. A white spot on an erythematous base is a Koplik spot. Ho gaya. Now what after Koplik spots? You say after Koplik spots 2 to 3 days later you're going to see a rash. Of course, we are going to see a rash, and this is usually a maculopapular rash. So firstly, if you look carefully, where is it beginning? So just imagine it's Holi and someone throws a bucket of paint or a bucket of watercolors on top of you. So how is that bucket of water going to go down? So first it will start from he's thrown it on your head, over your head. So first it will start from behind the ear. So where does the rash begin? You can see over here, the rash is going to begin from behind the ears. After that, you can see that it has come all the way onto the face. So from behind the ears to the face, then it goes to the rest of the body. Then it follows the rest of the body. So from behind the ears, then the face, then how it goes into the rest of the body, and then it starts disappearing also in the same order. It starts disappearing also on the same order, but this is the rash that has occurred. But you know what happens? Now please remember, when the rash appears, then the fever and Koplik spots are gonna run out. The fever and the Koplik spots are going to disappear with the appearance of the rash. That is a very famous line that is written in all pediatrics books. So we say that the rash is quite a dawn. When the rash comes, everything else is gonna run away. So coming all the way back, when I told you this concept that fever on the 10th day, then Koplik spots on the 12th day, and rash on the 14th day. So when the rash is basically present, at that time the fever and the Koplik spots disappear. Very, very important information that you have. Now a lot of pathogenesis has gone into why is this rash happening. Itna kya dawn hai na, they did a lot of stories and studies on it.
Question 10. A 3-year-old child presents with fever, loose stools, and blood in the stool. Which enrichment medium is used to isolate the organism from the stool sample? Your options are. And the correct answer is selenite F broth. Here's the explanation.
For the diagnosis, what sample will you take? Of course, you will be taking the stool sample. And again, I will ask you the INVIC testing. So remember one mnemonic, I am very, very shy. What is I am very, very shy? I am shy means only methyl red positivity will be seen in number 1 Shigella and number 2 Yersinia, which I'll be teaching you in a while. So repeating, it is minus, plus, minus, minus. Only methyl red positivity in Shigella and Yersinia. What is the transport media? It is the Sachs buffered glycerol saline. I know it's a little difficult to learn, but we will. Shigella ke liye Sachs buffered glycerol saline, and that is going to be the transport media. So S for S. Now I'm going to tell you something which might sound difficult here, but it's going to ease your life. If they ask you what is the enrichment media, and enrichment media is usually a kind of a broth, you have two, selenite F broth and tetrathionate broth. What did I say? Selenite F broth and tetrathionate broth.
Question 11. A patient who was on steroids for the treatment of chronic urticaria presents to the emergency department with acute worsening of respiratory symptoms. He says that he has been having a nocturnal cough for the last several weeks. A hemogram revealed elevated eosinophils. Bronchoalveolar lavage, BAL, specimen following bronchoscopy showed the presence of certain larvae as shown in the image below. Identify the causative organism. Your options are. And the correct answer is Stromalode stercoralis. Here's the explanation.
All this filariasis that I'm talking about versus occult filariasis. This is the first thing. Then I'll come to the diagnosis. So whatever I'm talking about classic filariasis, you will say, ma'am, wohi story that you were telling me, that adult worms are there. The adult worms are present in all the lymph nodes. So there is lymphadenitis, lymphangitis. All the lymph node and lymphatic wale organs are affected. All lymph that you were telling about, that classical story is classical filariasis. Okay, if it is such a classical story, I will ask you, where will you see the microfilariasis? microfilaria, the babies will be sent out into the blood. And then what will you do? You can do some ELISA wali serology studies, complement fixation, but it's not so sensitive. Best is you pick up the babies in the blood like the picture I was showing you. The ye wala pura story, ma'am, we know. We know this story. The adult worms are sitting in the lymph nodes. Everything is lymph nodes in the adult, and the babies are coming out into the blood. Ye pata hai. Now I want to talk about the other situation called occult filariasis. What is occult about it? Same. Adult worms are sitting everywhere. Babies are not coming out into the blood. Broad reaction. So the first question you asked me, are the microfilaria gonna come out? No, they will not. They are present. Babies are born, but they're not coming out into the blood. Tabhi to occult. Occult means hidden, na? The babies are hiding. The babies are not coming out into the blood. So now organism hai body mein, worm is there, microfilaria is also there. It's just trying to hide. It is not coming out into the blood. So can I say the patient will have reaction to the antigen? You say, of course, it's there in the body. The patient will have a reaction to the microfilarial antigen, resulting in an eosinophilic granuloma. That is what it will result in. And the organs affected will just not be lymphatics, but a lot of other organs, lung, liver, spleen, joints. Many other organs will be affected. So it's trying to hide and it's trying to idhar-udhar involve. It's a hidden kind of a smuggler kind of a thing. It's trying to hide from me. But at the end of the day, I will still show response because it's there in my body and so many organs will be affected. How is it hiding? It is not coming out into the blood. So what will I do? I will bring it into the blood. If someone, I am the police officer, if someone is trying to smuggle and trying to affect me, I'm going to give him a good drug and I'm going to get him out. I'm going to get him out with diethyl carbamazine. So that is known as DEC provocation test. That is known as DEC provocation test.
Question 12. Which of the following is the probable cause in a case of Tinea capitis where white powdery colonies were obtained from the hair specimen and the hair perforation test was positive on the isolate? Your options are, and the correct answer is Trichophyton mentagrophytes. Here's the explanation.
Hair perforation test. So what the sample that you're going to take from the patient is obviously going to be the hair, and you're going to incubate it with the fungus. Now, firstly, why do I want to do this test? Whenever I want to differentiate between two trichophytons, one is Trichophyton rubrum and one is Trichophyton mentagrophytes. So out of Trichophyton rubrum and mentagrophytes, I took the hair and I incubated it with the fungus. So what will I see in case of rubrum and what will I see in case of mentagrophytes? So remember, in one of them I saw that the hair remained intact. What it was 2 weeks before, it is 2 weeks later, it's intact. In the next one, I saw that there were some perforations in the hair that were forming. There were some wedge-shaped perforations that were coming up in the hair. So when there is no perforation, means hair perforation test is negative. When there is perforation, this means hair perforation test is positive. So remember, rubrum gives you a negative test and mentagrophyte gives you a positive test. How do I learn that? So I've learned it in the form of a Hindi mnemonic actually. I hope all of you will be able to correlate with me on that. So remember, when I'm talking about mentagrophyte, phyte is farna. Farna means perforate, right? So phyte is going to perforate or phyte farega. So phyte is farna. This means the perforation test is going to come positive in which one? In mentagrophytes. So remember, the men are going to fight and faro. So men fight a lot and then they tear each other apart. That is exactly how I've learned it. So mentagrophytes are going to show you the perforation test positive.
Question 13. Identify the class of immunoglobulin shown in the image below. Your options are, and the correct answer is IgA. Here's the explanation.
So what is it about IgA? What are the subclasses? We have been told that IgA can either be IgA1 or it can be A2. There are two subclasses out here. Further, you should be knowing that this activates which complement system? A for A. So it activates the alternate complement system. Next, we should be knowing there is a monomeric form. Monomeric matlab aise single antibody hoga. And then there is a dimeric form, two antibodies together. So either single or two antibodies. Monomeric form is going to be roaming around in the blood. Bloodmate's going to have a gala time, solo traveling in the blood. Whereas dimeric form is what you find in mucosa and secretions. What is this? Mucosa. This means whenever I breathe, the organisms, of course, when I'm breathing air, I'm also breathing a lot of bacteria. Which part or which antibody in the respiratory mucosa is saving me? The respiratory mucosa has IgA. Okay, that is why my antigens are not, everything doesn't cause pneumonia to me. Why? Because I have IgA standing over there to fight. Similarly, when I eat food, I eat so many random bacteria, but I don't suffer from food poisoning every day. Why? Because my GI mucosa has IgA fighting for me. So now can I say that IgA antibody is also known as a mucosal antibody? One thing. Second, it's also present in secretions. You must have read in pediatrics and obstetrics that breast milk is very, very rich in IgA. Why? Because breast milk is a bodily secretion. So can I say that this is also known as a secretory antibody? So now I'm sorted that your IgA is known as a mucosal antibody. It is also known as a secretory antibody.
Question 14. In the time frame of 1 to 4 months after renal transplantation, which pathogen is most commonly responsible for infecting recipients of the transplant? Your options are, and the correct answer is cytomegalovirus. Here's the explanation.
People who are immunocompromised. Immunocompromised could be people who are having HIV or people who are having a transplantation. They are all people who are under immunosuppressive drugs or are immunocompromised. One of the most common things that they have is CMV, chorioretinitis. In fact, let me tell you, the most common opportunistic infection in viruses, most common opportunistic infection in viruses in HIV and in transplantation is going to be the cytomegalovirus. So कोई भी immunocompromised state होगा, and they say which virus is going to be most commonly found in that state. It is CMV. What does it affect the most? Chorioretinitis, but it can affect all organs of the body.
Don't forget to like and subscribe if you found the video interesting. See you in the next one.